Going beyond the headlines. Asking the questions you want answered. Exploring government policies and how they impact you. We are delving deeper.
Good evening and welcome to Delving Deeper. I am your host, Ayana Carter. Joining us this evening is Dr. Marlon Timothy, Head of Department at the Neonatal Intensive Care Unit at the Port of Spain General Hospital. Good evening, Dr. Timothy, and welcome to the show.
Good evening, and thank you for having me.
Can you say if the Neonatal Intensive Care Unit is fully functional, and has there been any immediate changes or adjustments since the unfortunate deaths of the 7 babies?
Yes, certainly the unit is functional at this time. We would have begun readmitting babies on around the 10th of April. We would have received babies from the ward upstairs, our antenatal ward, who required emergency admission for prematurity and other conditions. So we would have continued to manage babies successfully since the events ended on around the 9th of April.
Have there been any adjustments or changes since the incidents?
So definitely, an event like this always triggers a different type of response within the hospital and healthcare system. So with that in mind, we would have had increased stringent techniques and protocols that we would have adhered to, and also double checking all of our existing protocols to see if there were any breaches during that time. We would have continued to increase our sanitization efforts in an effort to, of course, eliminate whatever contamination would have occurred so that we do not see a recurrence of that again.
Yeah. Now, at any given time, how many babies are admitted into the NICU?
So it depends. So each NICU has a bed capacity, and that bed capacity is the maximum number of babies that they can admit to the NICU. At Port of Spain, our bed capacity is usually around 28. We've decreased that over the last couple of years to about 24 to eliminate overcrowding. And so we can have anywhere from 10 babies to as many as 20 to 22 babies at any point in time.
Okay. And at this time, how many babies are currently at the NICU?
At this point in time, it's going to be about 10 to 12 babies. Presently, we would have admitted some and discharged some successfully since the event occurred over the period of April 2nd to 9th.
And staffing, do we have a full complement of staff for the NICU?
So that's a really interesting question, because when we are actually at full capacity, staffing is stretched pretty thin. So right now, with the lower numbers, of babies in the unit, about 10 to 12, we do have an adequate number of staff. However, we do not have an adequate number of staff to run a full unit. So if we go up to that 20 capacity, we then, of course, start to see gaps in the staffing in terms of the nursing to patient ratios.
Now, Dr. Timothy, what are some of the main reasons that a baby or neonate would be admitted into a NICU?
All right, that's a really good question. But first I'll start by defining what a neonate is. So a neonate is any baby who is less than 28 days old. So any baby can be admitted to the NICU after delivery. Prematurity happens to be one of the #1 reasons for a baby having to come to the NICU. Premature babies are, in particular, of course, not ready to be exposed to the outside world, having been come out of their mom's womb before time. And so that's our #1 reason for actually admitting babies to the neonatal unit. It's prematurity. Those premature babies will have things like respiratory distress. So because their lungs are underdeveloped, they need special care and help to actually transition from that in utero environment to an environment where they now can't breathe for themselves and need help. And so they would go onto ventilators and so on. Babies who have infections, born to moms who might have an infection, would be another reason babies would come into the NICU. Babies with what we call birth defects. these babies can actually come into the NICU as well. Sometimes it's known to us before delivery, but sometimes it might not be known to us, and only after delivery, when the midwife or the physicians examine the baby, they discover something is wrong, and they will call us to admit the baby to the neonatal unit. Sometimes babies who are being okay on the postnatal ward and sometimes with their mothers might also be admitted to the neonatal unit. For example, if we find that they're breathing too fast, or if they behave a certain way in terms of vomiting, not tolerating their feeds, if we find that they're getting excessively jaundiced or looking yellow, those reasons, again, we can admit that baby to the neonatal unit.
Okay. Now, stacking up Trinidad and other parts of the Caribbean region, what are numbers looking like in terms of mortality rates when it comes to neonates?
Yeah, so that's a great question. So Trinidad and Tobago has been steadily declining in its neonatal mortality rate over the last 10 years. When we compare ourselves to our counterparts in the region, we see Barbados has a number of like 8 deaths per 1,000 live births. Jamaica has about 10 deaths per 1,000 live births. Guyana has a little bit of a higher number, about 17 deaths per 1,000 live births. Whereas Trinidad and Tobago usually fluctuates at this time between 7 to 9 deaths per 1,000 live births. So one of the targets that we would have been using to measure ourselves against was the Sustainable Developmental Goals, which aim to have the Caribbean and Latin American region achieve a neonatal mortality rate of roughly 9 deaths per 1,000 live births. And so since about 2018, we've actually been able to achieve that in bringing down our rates to between 7 and 9.
Okay, and that, as you said, that is international rates.
Yeah, those are our international recorded rates.
Now, if possible, can you say how many babies would have died within the past 10 years in the NICU?
That's a bit of an impossible task because, of course, we have 5 NICUs in Trinidad and Tobago with 2 being developed in the last couple of years. So, what I can speak to is our declining neonatal mortality rates. So, for example, in 1990, the World Bank estimated that Trinidad and Tobago had a neonatal mortality rate of closer to 19 or 20 deaths per 1,000 live births. That figure has significantly come down since that time to where we are now of about 7 to 9 deaths per 1,000 live births.
Now, you mentioned some of the improvements that would have been made. Are there any other improvements in terms of the holistic side of things?
Definitely. Within the last 10 years, I could definitely speak because I would have returned to Trinidad about 10 years ago to help with neonatal medicine. And within the last 10 years, there have been significant strides in trying to achieve a better reduction in neonatal mortality as well as maternal morbidity and mortality, because if you take care of the mothers, then you have a better pregnancy, then you can have a better baby to take care of. So with the introduction of the Directorate of Women's Health in 2017, for example, that would have significantly impacted the course of the pregnancies in terms of access to health care, the things that are made available through the Directorate of Women's Health, educational campaigns that would have been launched to help mothers better understand their own medical conditions and how it affects the pregnancy. And that, of course, in turn would have helped us to see reduced rates of some of the other conditions we were seeing. So we were seeing, for example, babies who were being born to mothers who would have long pregnancies or long labors. People are seeking healthcare a little earlier now when they find out they get pregnant. We would have seen a significant drop in the number of people presenting without antenatal care completely. So, we would have had mothers who would not come to clinic at all during their pregnancy. And so that number has also significantly dropped. So there's been a lot of work done in trying to, increase the throughput through our healthcare system in terms of antenatal care, even postnatal care, where we discuss contraception with mothers and different other aspects of their own health that can help improve their readiness for future pregnancies as well.
Yeah, I know one of the campaigns that is happening currently is the baby-centered initiative, the baby-centered hospital initiative.
Yes.
Is that also part of that program?
Yes, absolutely. So the Baby Friendly Hospital Initiative is one geared at really increasing our rates of exclusive breastfeeding, not just in the hospitals, but throughout the country as a whole. You know, we know that breast milk is the best way to feed a baby. And so we definitely feel that, you know, being a baby-friendly country will significantly impact on the health of our, not just our neonates, but our children. Research has shown that babies who are breastfed have less chronic illnesses in childhood and adulthood, less prone to develop asthma, have less skin rashes and eczema, and so we definitely feel that it's worth the challenge and time to put into making sure that we all become baby friendly.
Okay. Now, back to the mortality rates. You mentioned that the standard is 9 per 1,000 births. That's worldwide. Is there any country in the world that has zero mortality rates?
Unfortunately, no, because there are things that we cannot control in pregnancies, genetic diseases, spontaneous mutations that result in the malformation of a heart or the kidneys and so on. You know, there's no country in the world that has a zero mortality rate. You know, one of the best countries in the world with a superb mortality rate is like New Zealand and Australia, where the numbers are as low as 1 or 2 per 1,000 live births. But there are countries in like sub-Saharan Africa, Asia, where the mortality rate can be as high as 60 to 70 per 1,000 live births.
Now, Dr. Timothy, well, would you be able to give the gross numbers globally on mortality rates?
Yes, certainly. The World Health Organization has produced estimates of what it sees as neonatal mortality globally. They estimate that 6,500 babies die per day globally from complications of prematurity, infections, and so on. Between 1990 to 2022, there has been a significant reduction in neonatal mortality, from a figure going from as much as 5 million neonatal deaths to 2.3 million neonatal deaths. And that's an annual figure. It's so significant, the neonatal period, that even in the first day of life, the WHO estimates almost 1 million babies do not live past the first 24 hours of life due to complications of prematurity and infection. So that is an overview of some of the global figures that the World Health Organization has for neonatal mortality.
Okay. What is the aim for Trinidad and Tobago? Are we trying to reduce, I mean, we're already within standard, but is there a push to possibly reduce the mortality rates here?
We are always striving to do better. So even though we've been set a target of 9 per 1,000, we know that we've already achieved a 7 per 1,000. And so we actually hope to introduce more interventions that can actually help us go even lower to 5 and 4 per 1,000. We know that that takes time, and it takes a significant effort by all stakeholders: nursing, doctors, administration, healthcare spending. So we know that that takes time, but there's definitely the aim to go lower.
Yeah, I know we would like to see 0, right? But as you said, you know, things happen.
An impossible number.
It is an impossible number. All right, so are there any conditions that you've seen here in Trinidad that no matter what, you know, what type of intervention is given, the survival rate is you know, there's just, you can't do anything about it?
Yeah, unfortunately, there are several deliveries per year. And again, not just at Port of Spain, but throughout the country, where no matter where this child would have been born globally, there'd be very little that can be done. So there are conditions where, if we look at a head-to-toe approach, the spine and brain, that malformations of that organ system can significantly impact the baby's survival. There's a condition called anencephaly, where the baby is actually born without the entire brain. And those babies, no matter where you are born in the world, will unfortunately pass away. Other cardiac conditions, so sometimes there's a malformation during in the embryo stage, And that can significantly, again, impact when the baby is delivered. If the right blood does not go to the right side, etc., then no matter, again, how advanced you get, you may not be able to save that baby. So there are certain conditions that, to which we are helpless, unfortunately.
Have there been any instances where parents of babies in the NICU have decided to discontinue life support?
Well, we have, so I've had experience with that both internationally and locally, where care is redirected, where the ongoing care or continued care is thought to be more harmful to the baby than beneficial. Babies who have significant abnormalities, who no matter how far we push, will eventually pass away. Sometimes the parents will ask us to not go any further and ask us to, just to make the baby comfortable until the baby has a natural passing. So both internationally and locally, yes, I've had that experience.
How often does that happen?
I can't say that it happens very often, but certainly it is something that we see in the neonatal units.
Okay. Now, I've heard about the viability age. Could you explain a little bit about what that is?
Yeah, so globally, each country sets what they call a viability age. So WHO in the earlier years had set a target of about 28 weeks and 1,000 grams. Over the last 10 years or so, maybe even beginning in about 2005, we would have started seeing more babies below the 28-week range who could have a chance of survival, and so we began taking a chance on some of those babies. To date, we're about 50% successful in babies who are between 26 and 28 weeks as a country. So we have seen them survive, but our official viability age is still about 28 weeks gestation. So, we do try our best for, many of the smaller ones, even though we know that it's a 50-50 chance.
Okay. And how is that used when admitting a baby into NICU?
Yeah, so definitely we would assess all of the data that we have in admitting a baby. So, in Port of Spain, for example, we would admit the smallest babies in Trinidad and Tobago. So we would have admitted babies sometimes who are above that 26-week range, but even as small as 400 or 500 grams. Some of those babies, again, if they're mature but small, or had maternal conditions that restricted their growth, we will still try to see if we can produce an outcome there as well.
Okay. How do babies in the NICU who may not be able to traditionally breastfeed, how are they fed?
When babies are admitted to the NICU, especially preterm babies, they are fed mostly intravenously for the first couple of days while we stabilize them, get them set up on the ventilator, and get their respiratory parameters and cardiac parameters all settled. They are given a special formulation called total parenteral nutrition, which has all the basic requirements of sugar, electrolytes, and even amino acids to help create an environment that allows them to grow.
All right, so how is that used when determining how babies are admitted into the NICU?
All right. So we would actually do an assessment of all the babies based on the data we have, the maternal data, the ultrasounds in the pregnancy, and so on. We'd use all that information when we're admitting the babies. In Port of Spain, for example, we'd admit very, very small babies. So even though they're under 600 grams sometimes, we do an assessment. There might be an instance where the maturity is actually higher than the 26 weeks, so 28 weeks or 27 or 28 weeks, but they might be small because the maternal condition restricted their growth, etc. We would still give that baby an opportunity to be admitted to the NICU and try with that baby.
Now, how do premature babies feed if they're not able to traditionally breastfeed?
That's a really important question. So most premature babies, when admitted to the neonatal unit, aren't fed immediately. we actually feed intravenously through the veins of the baby. So what we will do is introduce IV fluids in a form of what we call total parenteral nutrition, which has all of the essential sugars, minerals, and amino acids that that baby would need to start growing. When the baby is deemed fit for feeding, what we love to start is the colostrum from the mothers. So we allow the mothers to express that colostrum. We save that, and then we introduce that as the first feed, especially for preterm babies. If you introduce things like formula into preterm babies very early, it actually can kill the gut. And so it's a real balance of, trying to advance a baby with feeding who is outside of the womb versus the level of prematurity. So we know that breast milk still remains the best option, and so we prefer to use that as the feeding option. So mothers would express the milk and give it to us in the NICU, and we'd use that milk to feed the babies through tubes. Unfortunately, babies cannot suck at that time. So we'd put a tube through the nostril or sometimes through the mouth, straight into the stomach, and we'd put the milk down the tube to feed the baby.
Now, if for some reason mom is unavailable, let's put it that way, what happens then?
Well, unfortunately, we do not have a donor milk bank in Trinidad and Tobago. And so, in other countries where you have donor breast milk being available, that is something that is readily available to most NICUs internationally. However, if we do not have a mom available, or mom has had an unfortunate circumstance or cannot breastfeed for whatever reason, or produce milk for whatever reason, we will unfortunately start a premature modified formula. So we do have special premature formulations of formula that we will then have to administer to the baby.
Okay. Now, how common is infection when it comes to preterm babies?
Infection is probably the most common thing seen in preterm babies, and that is because a baby who's delivered preterm really does not have a functional immune system. Even the bacteria that colonizes the gut of the baby after delivery can actually become even harmful to that baby, because the immune system is so weak at recognizing good or bad bacteria that bacteria in that baby's gut can actually make that baby ill. So because the immune system is so poorly functioning, they are very, very prone to infection. And you can imagine, there are thousands of moving parts in the NICU around a small baby: IV lines, feeding tubes, ventilators, ventilator circuits, So there's a lot of movement in terms of around the baby. And so any opportunity that bacteria can see to try and infect these babies, it will.
Yeah. Now, you mentioned upon delivery, sometimes if an infection is not caught before delivery, that during delivery or post-delivery, the baby can be infected through the mother that way. If the baby is in the NICU, can they also pick up infections from their mom or parent, I should say?
Yeah, unfortunately, yes. So we do have strict protocols in the NICU for isolating babies, for hand hygiene, for touching babies, for sanitizing equipment even around the babies. Unfortunately, yes, we do see some circumstances where babies would have picked up infections, sometimes from the mothers, sometimes we don't know what the exact source is, but we would definitely still isolate and treat as best we can.
Okay. Now, how long can a baby stay in the NICU?
So a baby can stay as long as is needed until discharge. So we've had instances where a baby can be admitted to the NICU. So if you are an older baby, and by older I mean a baby who has an advanced gestational age, so greater than 36 weeks or 37 weeks, you might be admitted to the NICU for phototherapy or for screening for infection. And that could take sometimes maybe just 2 to 3 days, and you might be able to be discharged. However, the smaller you are, the longer your stay is. So a baby coming in, let's say at 600 or 700 grams, would have to stay sometimes in NICU, sometimes as much as 3 months before they can put on the appropriate weight gain or be off the ventilator and be able to breathe on their own in order to then go home with their parents.
How many beds are there in NICUs across the country?
So we do have about 90 to 92 beds in all of the NICUs. So there are 5 NICUs in the public health sector. So Port of Spain, Mount Hope, and San Fernando are considered level 3 NICUs. This is where the highest acuity care is available for babies, including long-term ventilation, surfactant, etc. At Sandy Grande and Tobago, we have level 2 NICUs, and those NICUs will admit bigger babies who would have shorter stays. So in total, with those 5 units, we have about 90 to 92 beds.
Okay, and at any point in time, are they filled to capacity? Are all the beds being used?
Sometimes when we get to busy season, we can have full capacity nationally. However, with a declining birth rate, we've seen that we've had some space of recent, and so, but it can be at capacity in the busy peak seasons between August and December.
Because I was just about to ask, what is the busy season?
Yeah, between August and December, we usually tend to see a significant peak, unfortunately, in both normal deliveries and preterm births, and that can significantly overwhelm the units. Remember, if we admit a baby who is, let's say, 28 weeks, and that baby is staying there for months at a time, then that bed is blocked for those exact months. In that time, you can have a significant number of other babies being delivered preterm. So if we take into consideration that we are blocking beds basically by months at a time, then yes, we can sometimes reach capacity.
So what is the average cost per day for a baby in the NICU?
So we've actually made some rough calculations based on, the average stay of some of these smaller babies, right? We estimate that some preterm babies, it can cost anywhere between $16,000 to $25,000 per day for that baby to be cared for in the NICU. So the smaller you are, the higher the cost, because you consume a lot more products in us trying to keep that baby alive. For example, one product that we use in the NICU is something called surfactant. Surfactant is a natural product that all of us produce in our lungs, and it helps us to breathe and make our lungs, non-collapsible. Preterm babies, however, do not have sufficient surfactant to breathe on their own, which is why they need help after delivery. Sometimes we can use up to 3 vials of surfactant, trying to get surfactant into the lungs of the babies, and that cost alone is $5,000 per vial. So you're looking at sometimes $15,000 just in one product alone, surfactant, being delivered to a preterm baby. So, that significantly increases the cost. So when you think about running a ventilator, all the oxygen and the gases, the medication, the tubes, the incubator, it stacks up very, very quickly. And so a conservative estimate, and I say conservative, could be anywhere from $16,000 to $25,000 a day for a small baby.
And that is TT dollars, not US dollars. That's
TT dollars, yes. However, in the US, it's significantly more. I've heard of parents getting bills on discharge from the NICU that ran into millions of US dollars.
Now, as we wrap, what kind of assurances can you give to pregnant mothers who are seeking care through the public healthcare system?
Definitely that care continues throughout the entire healthcare system. Remember, we would have seen, let's look at last year, for example. There were over 12,000, almost 13,000 deliveries last year. Of those 13,000 deliveries, roughly 1,600 babies would have been admitted to the NICU last year. Our mortality rate for last year is still under 9 per 1,000 live births. So, general care continues throughout the country, throughout all of the maternity and neonatal units, throughout all the postnatal wards. Care continues. We have also continued care at Port of Spain. We've had the babies discharged this week, even up till yesterday. We've had discharges. We might have a few more discharges coming up this week as well. So care continues. You know, we continue that care, of course, with a significant increased vigilance, making sure that what happened to us in that first week of April does not recur again.
Well, let me thank you, Dr. Timothy, for taking the time to be with us here for this episode of Delving Deeper.
Thank you for having me, and good evening.
So join us again at the same time next week for another episode of Delving Deeper. I am your host, Ayana Carter, and from all of us here, have a good night.